on, you will see a poll in the right-hand side of your screen. So if you can answer those questions, that'd be great. And I would like to welcome everyone back to part 3. And we're really going to cover Standard 3 and Standard 4 today. So identify at-risk patient populations and making a difference in patient healthcare outcomes. So we're going to go ahead and get started. For those of you who've been joining the series, some of this may seem redundant, but some of you are new today. So just a couple things to note. As you come on today, you were automatically muted. I will have an open Q&A session like we've had in the past ones. Also, if those of you who are shy, please don't hesitate to put questions in the panel. So you'll see in the right-hand side of the screen here that you can put in a Q&A, type it in, you can send it directly to me, or you could do it to everybody on the screen if you want. It doesn't matter. I'll answer all of those at the end. Any formal Q&A, whether they're verbal and or if they're written, we'll make sure that they're published after this. Also, if you need to see the screen bigger, you can enlarge it here. Again, for the open session at the end, I know some of you I've been in communication with, just talking through things of what's happening in the organization. So don't be shy. I know some of these run long. I'm hoping today we can keep it succinctly and have some time at the end. But it's a great opportunity for you to sort of hear from others what they're doing through their PCMH efforts and how they're transforming their practices. And it's me again. This is Christy Erickson. Some of you are starting to recognize my voice now on part 3 of a 4-part series of PCMH. I'm the Director of Clinical Transformation here and a nurse practitioner. The bulk of my career with the last 10 being in the lovely realm of healthcare IT. So we're going to go ahead and get started. Today, again, I'm going to do a little bit like I did last time, but some of you are just joining for the first time. So I will do a brief PCMH overview. For those that were not aware that this was a series, we did begin this in March, and I did an introduction in March, and then in April, just a couple weeks ago, I did a deep dive into Standard 1 and 2. So if you have not, if you've attended those, then you already got the decks, the recordings sent to you. If you didn't attend one of those, or if you're brand new today and you actually would like to go back and see those, at the very end, you're going to see options. You can certainly go for our webcast and see them. Also, at the very end of the session, you don't want to have to go navigate anywhere. I don't expect you to. You're going to get a box when you close out your event meeting, and it's going to say additional feedback. If you type in there, I would like to have number 1 and number 2 sent to me, I will make sure you get an email directly from me that has those recordings if you do not attend. Either one of them, both, I'll send those out to you. All right, so the first part will be a brief PCMH overview just to make sure we're on the same playing field. But like I did on the last one, I will then do a deep dive of Standard 3, which is Population Health Management, Standard 4, which is Care Management and Support. Again, same similar format. I did ask feedback on the last one if people liked it or they want to change. You know, I'm going to tell you the logistics of the scoring, but then I'm going to give you examples that you can utilize and simulate in your practices. I'll also cover any changes for those of you who may be on 2011 now and already recognized on 2011, who need to, or be coming up for your renewal in 2014. And because of the modified ruling of last year, there were some modifications to the original standards that were published in 2014. So I'll sort of highlight NCQA's stance on how that modified ruling affects the NCQA requirements. All right. So just like the last time, I'll bring this to light again. And this is important. For many of you that are on this call, I'm making presumptions that you sort of are interested in PCMH, and maybe you were interested in it before you heard the word macro. But if you were not, I will tell you, and you can certainly socialize this idea. If you didn't know macro, there's a proposed ruling out for the next 60 days. Came out on Wednesday, the end of April, the 27th. And that really looks to changing the way we deliver health care. Congress passed this law over a year ago. It's now instituted. And basically, in a nutshell, starting January the 1st of 2017, every organization that sees Medicare patients, so this is ambulatory Medicare, so not Medicaid, and not hospital are going to fall in two paths. And essentially for year one, everyone will fall into MIPS. It gets a little complicated. And my topic will not be much about NAPR today, but I want to highlight something here for those that are doing the PCMH path. Under MIPS, clinical practice improvement activities is going to be 15% of that. And if you are a PCMH recognized practice, you will get the total points allotted and get the full 15%, and it's basically 60 points if you really need to know. So you can see where PCMH will align with some of the clinical transformation you're seeing in healthcare, moving from quantity to quality, and fee-for-service to value-based care. So I bring this to the forefront because you may hear more about it if you're just getting in and dipping your toes into the PCMH world. This is more of a reason for you to do that, to sort of secure those points. Now, there's other things you can do in that bucket. It's not strictly just PCMH. Also PCSP, if you're a specialty practice, that would also qualify. And there's other areas that you can focus on, but it is good for those that are considering PCMH to get those points automatically. All right, so with that, let's do a brief review on PCMH. Again, patient-centered medical home. It's designated to primary care providers program. Primary emphasis in that you have a personal physician. Shared decision-making with your patient, and we're going to highlight that today, actually, and you're going to see some examples of what we mean with patient engagement and shared decision-making, which is part of the tenets and the characteristics. It's about having the whole patient care, not just prevention, not just acute and chronic, but from birth to end of life. Care coordination, we'll talk about that a little bit today. That'll be also the main focus on the next session with Standard 5, but looking at referrals, labs, follow-up, engaging providers within the community. Care management, care plans, treatment goals. We'll talk about that a little bit today. Self-management, that's going to be in the topic today. And then enhanced care, expanding office hours. And all of that's leading to triple aim, right? Lowering the total cost of healthcare, but really finding improving the health of the right patient population and improving the experience and the quality outcomes of those patients. And again, for those of you who have been on the series, some of this may be similar, and for those who have completed the poll, I do appreciate that. The next thing before we get into Standard 3 is, again, if you have not received the standards from NCQA, I do recommend you go to their website, download the standards. I'm basically succinctly pulling out key points, giving you examples, but you're going to need to understand these at a deep level. We'll talk again, if these are new concepts, about the must-pass elements. In this screen, you'll see anything that's bolded is a must-pass. And as I've been mentioning, for those that have been here, for those that are new, your focus, if you're just starting out, is at least read through the must-pass first. See where you fall in that line. That's the best first gap analysis I can give you, because if you do not meet the must-pass, you will never get recognized. It's flat out. That's how NCQA sort of highlighted must-pass elements. If you pass them, then you'll at least get to a level 1. Level 1 is the lowest, and level 3 is the highest, and you can see the scoring levels. And again, a lot of this might seem repetitive. It's a lot of information that comes to you in this program, as well as the whole of these programs, as most of you who might have heard of NAPR and have been sitting on some of those CMS web calls, it's heady stuff. So I hope to make it as simple and understanding as I possibly can, and we'll continue to repeat it to make sure people get comfortable with it. Okay, so let's go ahead and get started. Today I'm going to talk first about PCMH 3. Both standards today have significant numbers of points on them. They both bring 20 points of that total 100 you're getting. So we're talking about almost, a large portion of, 40% of your points are going to be there. The intent of this standard of population health is really that you're using a comprehensive health assessment and evidence-based decision support on complete patient information and clinical data to manage your entire patient population. There's 5 elements. You can see what those are, and we'll go through each one of them and how you get the patient information and clinical data what does a comprehensive health assessment look like? How do you use that data from population health? And then how do you use and implement the evidence-based decision support? Again, I'm going to continue to try to get you in the naming convention of element 3A, and the first one's going to be patient information. So a lot of this may seem very clear. You'll see the first 5 that are listed here have those little plus signs, and this is really looking at you capturing, and many of those, you'll see in the next slide how it aligned to me. Many of you have probably been capturing this. What I will point out now, and I'm going to read it again, 1 through 13 here has to be searchable data and structured data fields in one of your systems, be it your PM or your EHR. They're going to have to be reportable with numerators and denominators. So that's important to think about and get each one of these. You know, obviously for number 8, where it says occupation, where it says number 12, for those of you that are pediatric, you will see when you're submitting this data, NA are not applicable available to you, and that means those points don't go against you, because obviously we don't expect little kids to have occupations and be applicable to them. So those don't score against you in those total points. And we'll go through some of the examples here. Meaningful use alignment. So I call this out, one, to tell you what the NCQA response is, but as you know, late last year in the modified rulings between 2015 and 2017, getting race, ethnicity, and language was something that was dropped. However, NCQA believes, we've talked about this in our previous sessions, you know, culturally, linguistically aware, you really need to be able to understand your patient population. You need to be able to give the education pamphlet. Do you have certain languages that are predominant that you're tailoring to? Are you providing care and recognizing someone's culture and how they may or may not perceive the information you give them, how they might manage their own personal self because of their cultural beliefs. With that said, NCQA stance is this doesn't change. What I'm going to highlight when we get to the reporting of this in a minute is, will you still be able to get this information from your system? So this is 3 points, pretty easy. You'll see there's not a must-pass or critical factor. Don't worry if you're new and you're just hearing this for the first time. I'll show you. We have some must-pass coming up in critical factor. And you can see what you get. So remember, if I just do 2 factors, this is one where you can do some and still get 0 points. So really when you're looking to do this one, obviously we all want to be 100% super rock stars, but we also understand you guys are the people who are probably designing and rolling this out. We also have end users and patients who may not have information, might not get it. We know how it is to deliver healthcare, but here's the point percentage breakdown and how many points you can get total of the 3 points and how many factors you have to meet. So here's where I'm going to emphasize. Again, 3A, number 1 through 13. So a minute ago I showed you what we're talking about: ethnicity, language, email, occupation, healthcare proxy information. Has to be reportable data. Has to be 3 months of recent data when you go to actually submit for your survey submission. Has to be in the numerator and denominator. So some of you, depending on the electronic health record you use, and when that modified ruling, some electronic health records have sort of said, well, you don't need that information because CMS doesn't need it. You need to figure out, do you still have access to that? Do you need to build your own custom reports, whether it's from your practice management or your EHR? Which system are you putting that data in? And can you get that data? So just because it's gone away from meaningful use, and even that terminology of branding of that name change, will you be able to get the data? And then 14 really is looking about a policy and procedure. Do you really have the ability to go, it does not have to get the unstructured data, but you're going to have to give 3 examples of that. And we've talked a little bit about what examples, and I'll show you some reports and examples to look at. So I think this one is pretty straightforward for most people. Again, I'm looking for a sample. Please remember these are at the practice or site level. So although you might have meaningful use reports still available to you, and this is like record demographics that's capturing language, race, and ethnicity, you need to roll that up to the practice or the site level. And again, I'm highlighting, make sure after the modified ruling that if you've accounted or said, oh yeah, we can get those because of our meaningful use reports, make sure you still have access to them and that your vendor hasn't changed that on you in any way, shape, or form. Also, tips and tricks when you're submitting this into the survey tool, things that reviewers look for. Again, what is the actual report you're giving me? If you're going to call out that this is 3A, 3 through 5, so it's covering the race, language, and ethnicity, make sure you have the dates, that it's showing 3 most recent dates before you're actually submitting, and that you have the numerator, denominator, and you're showing the scores. Here's an example of a 3A, 1 through 7, and 9 through 13. Maybe you have the ability to do a custom report. And if that's something, whether you do it in-house, maybe you're outsourcing to someone to actually build these reports to you. Again, make sure you cover, again, I'm showing 3 months. I'm showing January 4th to March the 4th. Make sure you're showing the data within 3 months. And you can see where I'm pulling this out, whether you're pulling that out of the data warehouse, maybe you're getting some of it from your practice management system. All of this is whether or not you have that available to you. And again, if you have pediatrics, you don't necessarily have to put in the advanced directives. That's not applicable for the pediatrics. And honestly, nor is legal guardian, depending on your practice type. So let's look at 14. We talked about this is a policy, so this does not have to be structured data into your system, but you really need to call out, are you collecting that? So they're looking to see if you have a policy in place, who is the person that's responsible for collecting it? And I've talked about this in other ones, but please make sure that every policy and procedure has your practice name on it, when it was instituted, and at least annually you should be updating and revising these policies and procedures and stamping them. I think I mentioned this on the last call, but I feel like if I repeat things, you can only absorb so much, so maybe you hear it the next time. Please understand in the PCMH model redesign that's happening in 2017, there could be a chance that standards are tweaked. They usually improve or adapt. I cover them at the end of, you'll see how they've changed slightly from 2011 to 2014. For those that don't know what 2011 is, you'll sort of see a little bit of that and what's new. But I will tell you in the redesign, there is the intention that you get recognized for 3 years. In that 3 years, you can be audited at any point, right? And that's just like same for many of you. You might know meaningful years, so you know you could get audited. In the redesign, you will have to have an annual submission or sort of process where you have to give some of this information. So please make sure if you are in the process of doing policies and procedures or you already have them, if you don't annually check them, that's something you really should sit down with your core team, decide if they're still applicable, and make sure you date those because your reviewers are going to be looking for that. Also, you can see where, I make this easy for submission purposes to say, okay, well, this is my policy intake process that we do for new people. This is how we do our business in our organization. But you can certainly tag on here 3A14, so it makes it easy for you to go get the information. Or if you have them in a big binder in your office, when you're up for renewals or when you're up for these an audit or when you're up for the annual things that will come in the redesign that are still being defined, you can quickly go find those. So a lot of tips and tricks here to help you for the ongoing process. You do not have to highlight this and sort of say the name, but certainly reviewers are used to clients and organizations submitting stuff like this so that it makes it easier for them. Again, I've said this before, if you don't do this, it's not a problem. Sometimes people do this and it's not the right one, and we'll see the right one that you need to use. It's fine. You don't have to. It's nice to have, but sometimes it helps you if you're the person doing the actual submission and putting all the documentation out there. It helps you a bit. And then here's a sample. Remember, you need 3 samples to submit, and it's showing the capability. And you can see down here where I have care teams available to me, right? I have the ability to put the physicians and the different people that are involved in their care. All right, let's move to clinical data. Again, a lot of plus signs, meaning it's a lot to do and related to meaningful use. This is about the up-to-date problem list. I'll go through on a minute on how that's aligned and the NCQA response. So for many of you that are used to meaningful use, does your system have an up-to-date problem list? Do you capture the allergies? Are you covering the blood pressure for your patients and making sure for 3 years and older and 80%? Does your system have the ability to do height and length and weight? Do you have the ability to calculate and display a BMI, growth charts, smoking statuses for 13 years of age of older? Are you reconciling your medications? Are you capturing the patient family history? And do you have an electronic note? Now again, for those of you that have been very familiar with meaningful use, you'll know some of these things are no longer required, right? That dropped. Well, here's the stamps from NCQA. For 1 through 10, they're still required. So I bring this up just like I did on the last one. If smoking status is something or family history is something that, you know, you train the users, they did it, they adopted, they got the numbers, but you're starting to see numbers drop. Although it's not required for meaningful use, if you're trying to get recognized from NCQA, you're still going to need to meet those standards. The caveat is on the electronic progress note. So it was greater than 30%, and although it was removed for MU as a measure, NCQA at least will accept an example of capability. So you just have to show capability in your report. So you don't have to meet those numbers, but you still have to give a report, the example of that you can see that you can do an electronic note in your system. Again, pretty straightforward. 4 points. You see the breakdown of the points. Again, you can do 2 of those factors and get nothing. No critical factors, and there's no must-pass factors here. And then, obviously, factor 3, if you don't have patients over 3 years of age, you don't have to get their blood pressures. Factor 7 is not applicable for adult practices. And just be cognizant of what your practices look like. For those that, for factor 7, if you're not doing the growth charts, you're going to have, and you're going to score when you go in, you're going to put not applicable. For every not applicable response that you give, you don't get negative scoring for you, but you will have to have a written explanation, and there'll be a little comment box. So just to put not applicable doesn't mean that they understand that, hey, look, I don't see peds. I'm an internal medicine, I'm a family practice place, but I don't do pediatrics in this place. Then you'll have to make sure, or vice versa, if I'm just a pediatric place and I don't have it for, I'm going to have to say I'm a pediatric practice. So what's that documentation look like? Well, this is pretty easy, right? Some of you have been capturing this. Please make sure that you absolutely still have access to some of these. Remember, as I mentioned earlier, your vendor might have removed the capability to see that. Or maybe they left those old reports in your system, or you still could pull them if you wanted to. So just make sure if you are no longer tracking to them because you haven't looked at them and you're only looking at modified reports, you really need to have visibility if people are still tracking and getting to the threshold they need for the PCMH recognition. Same story, 3 months of data, numerator, denominator. For 6 and 7, I'll show you some examples. You need screenshots. And then lastly, for 11, you can give them a numerator and denominator, or you can show capability. So that's what that asterisk is here. You don't have to do both. If you give a report because you're still doing electronic notes and that happens to be on a report that you have accessible, whether it was a stock delivered by your vendor or maybe you've done a custom report, if you do it here, you don't have to show the capability to. But if you don't have a report available and you can build an actual note in your system, then you just need to have a screenshot based on the modified ruling. And then straightforward, right? Sample report says what I'm looking for, gives all the measures that I'm covering here. I'm highlighting for the reviewer, if you will, which factors I'm covering. I'm giving the practice, the numerator, denominators, and you can see those thresholds. Pretty straightforward, nothing new and shocking there. Should be pretty easy for folks to understand that one. Some of these first ones are easy. And again, for 6 and 7, screenshots. Do I have the ability and can I show that I can calculate BMI? Do I have growth? Am I capturing the information? So again, make sure if it's asking for 1 screenshot, 3 screenshots, it's little things like that when you're collecting the data that you get the information. And I've mentioned this before, but make sure that you're not giving any patient identification information, PHI information that you're putting, although it's secure, and NCQA does not want to see any of that stuff either. All right, so far, those seem to be relatively easy ones, right? We've done things with meaningful use. We're used to testing for people, for those that are in the ambulatory space. This is not new to you. However, there are other things that aren't so reportable and may be more challenges to you. So this is the beginning of one of them. And again, this is looking at performing a comprehensive health assessment. Do you capture, and under element 3C, you'll see there's 10 factors here. And do you capture age and gender appropriate immunization and screening? Are you looking at the social and cultural characteristics of the patient and their family? So am I looking at maybe what their household environment risk factors are? Are there a variety of characteristics such as poverty, homeless, unemployment, sexual orientation, gender? Those are the types of things that we're looking for number 2. Do I have communication needs? Do I have any hearing or vision, cognition issues? And this isn't about language, right? So this is separate. I want to be clear that we just went over to PCMH 3A Factor 5. This isn't about language, right? I'm really talking about, are there some obstacles to being able to communicate with your healthcare care team that's going to be performing? Family history, number 4, family medical history. What do I have? So again, if you don't know it because they're adopted, you can certainly put unknown as their family medical history, and that would count. Same thing, we're looking for first-degree relatives if it's known who those are. Advanced care planning, pretty straightforward. Again, not applicable if I'm in pediatrics, and you will have to write in the survey tool in a field called support text notes that you don't have that. And then behaviors affecting health. We're really looking for risky or unhealthy behaviors. So looking for, maybe oral health, dental care, nutrition. Is there secondhand smoke exposure? Do I have risky sexual behavior? That's what's driving number 6 when we're saying behaviors affecting the health or that could impact your health. Mental health substance abuse, pretty straightforward. And then the next 2, developmental screening tools, a standardized tool for pediatrics as well as adults. So if for number 8, I'm just a pediatric, then I would say NA. And then if vice versa, if I'm dealing with the, if I don't have LSMs, I don't have to worry about that. And then the last one is, basically, do I know the ability to understand concepts and care requirements related to their managing their health? What's their health literacy do? If I say terminology, and we'll talk about how we assess that. 4 points for this one. Again, no must-haves, no critical factors. And then the documentation. So for 1 to 10, you're going to need a report, 3 months, numerator or denominator. or the record review workbook. Now, I'm going to show you a screenshot of the record review workbook because my guess is the majority of you will be doing that unless you've got a great custom report writer or an amazing electronic health record vendor who can pull this for you. But as we covered some of these, the comprehensive health assessment, risk data, a lot of that data is in a system, whether it be in most of the cases, it's going to be an electronic health record. But for many of you, that's not going to be a report that you can push a button and spit out. So I'll show you a screenshot, and I'll talk briefly about the record review workbook. On the other hand, I'm going to focus it more when I get to 4 because that's where almost everyone uses it for 3C and the 2 elements in 4 that we'll talk about in a minute. In addition to that, for 3C, 8, and 9, I am going to have to show basically someone filling out the depression survey, and I'll show you an example of what that means and what we're looking for when you do that. So for 3C, when you get in, and if you just download the standards, that's great. Once you get farther down the process and you go and get your application, and then you get the tool, then there's a real investment into it because you're going to pay $80 just to get the application, and there's, depending how many people you have, there's pricing on it. And I'm not going to go into that in the series, but essentially the record review workbook, for those that can't get reports out, essentially what you're looking to do is to go through and do a chart audit, and these are those same things. You will be having to ask and go through, you're going to have to do 30 patients, and I won't get into how recent they are, but you can see there's instructions in the book, and this is all through a system within NCQA that you can use, and you'll download this as part of your survey submission. And you're going to say, on patient A, now remember, it's de-identified. NCQA doesn't want to know who those patients are, but one tip I'm going to tell you if you don't remember this, for every patient number, you're just going to know, they're going to know them as 1 through 30. And you're either going to say, yes, the information's in there, no, it's not, we don't use that or see report. So for some of these, you might be able to pull this out, right? The medical history of patient and family, if you can get that out and you have the ability to pull that in a report, you would say see report and you would just attach that along with the record review workbook. With patient 1, I'm going to recommend that every single one of you, when you do the record review workbook, and my guess is you're going to use it for certain aspect here, please make sure you know who patient 1 is. Keep it separate, keep it in a folder someplace where you know patient 1 equals MRN XYZ, date of birth, name, because when you come back for an audit, if they say, I want to go see this, you're going to need to be able to show them that. So if you're super, I don't want to say I'm OCD or crazy, but most people will call me crazy. I would tend to say number 1, and I probably would do number 1, here's the MRI, and keep it on my internal system, do the screenshot, so that when the person comes in, I'm not going to be showing them that because I'm going to have to get into the record to actually show them the electronic health record, but at least I'll remember because that process could be a while after you've gone through your submission and after you're already recognized, for example. So, you know, it's okay to say you don't use something if the practice doesn't use it or does not document that information in the medical record. And at the end, you'll see that these patients will accumulate and you'll have a score at the bottom of the element based on this, and it's going to give you that score. So the workbook sort of does most of the work for you. And you'll see when we talk about PCMH 4A, and when we get to 4B, this is going to make a little bit more sense in how you've got to collect the data. Basically, it's one sheet, and they're all the tabs across. So this is only covering 3C comprehensive health assessment at this point, and whether you capture this information. Again, keynote, you can do a combination of reports and or chart reviews, but this may be labor intensive for you. The other example I wanted to give you was the de-identified data. So again, you're going to come through, you're going to be able to show, make sure you get rid of the PHI. You're going to have to show where they were able to, where the patient scores lied, an example of how you collect that and what the patient score was into the system. So capability of your system to get that data. And that's for both 8 and 9. You'll have to give examples of that. All right, so let's move on to 3D, use of data for population management, must-haves. So again, must-haves, for those that are brand new, that haven't been attending these or haven't quite grasped that concept yet, a must-have means you've got to get 50% or higher of this measure. This is one to focus on. So what we're looking at, and you can sort of read these, some of these are related to and some are in a meaningful use. We're looking at least annually the practice of proactively identifying populations of patients and reminding them or their family or caregivers, whatever is appropriate, the need of care based on that patient information, their clinical data, health assessment, and evidence-based guidelines. So we'll talk a little bit about some of these to make sure people grasp this. So for the practice generates a list of patients, looking to see if you remind them that they've got preventive care services that's appropriate to their age or gender. So, you know, well-check visits. Am I going through pediatric screenings, mammograms, maybe stress tests or flaxing? Preventive services consider the practice's entire population. So I'm not just looking at chronic conditions, right? I'm looking to see, am I doing this, you know, are you sending my mammogram reminder if I'm overdue or if it's upcoming? That's what the intent of number one is, of preventive care services. Number two is really looking at, do I remind people, and for this one, you can't use the same immunization for two different age groups. So, you know, for number one, if I'm doing well checks, I can say, look, you're due for your 3-year exam or your 2-year exam of your healthy well check, but at the same time, I'm not saying, and by the way, I need you to get, you're behind in your immunization. This is more like, am I doing influenza, pneumovax? Am I targeted certain populations that I need to have that? The next one's a little bit easier, right? For practices, am I generating lists? You can use registries for this. And these are people who do need chronic care services or acute service. So here's some examples. You know, for adults, you know, maybe you're doing diabetes care. Maybe I'm looking at all the diabetics and say you don't have a foot exam. You need to go and get this or an eye exam. Maybe I've got, maybe it could be as simple as lab values. Maybe I've got coronary artery disease and I need people to go and get lab values to see where they are, or post-hospitalization follow-up appointments. All of that would work for chronic or acute. For children, things like maybe I've got a chronic condition of asthma, maybe it's ADD, obesity, depression. Maybe I'm bringing them in and suggesting that I want to check you on your medications, want to do proactive or preventive acute to try to maintain them, haven't seen them. Those are some of the things of chronic care services that people might use. And then do you look at people who haven't been in your practice for over a year? Or if I've got a diabetic and I have made a stance that every 6 months I want them to come in, but I haven't seen them come in and they've missed their hemoglobin A1C, they've missed their lipid panel. Trying to find the pockets of holes of those who fell through the cracks. That is really what the goal is here, is that we're taking care of the entire patient population and that we don't have anyone falling through the cracks. And then the last one is medication monitoring alert. So this is for people on high-risk medications. Maybe you look at all the people who, you know, I don't know, Coumadin could be a risk, right? I'm trying to think off the top of my head of some examples here that I want to make sure that they're getting regular monitoring. Maybe I've got people on antifungal medications and I want to make sure they've had a recent liver test. You know, there's no strict rule. You would just define as a group, what is the patient population? In order to decide who you're going to go after, the intent is that you're going to evaluate your patient population, right? NCQA is not asking and telling you you have to do X, Y, and Z. They'll give you examples. But what they're looking for is that you haven't looked at your patient population. So if you've got a lot of diabetics, you've got a lot of heart disease, maybe you've got kids, and maybe you have an ADD specialist in your site. You're focused on your practice and trying to improve the quality of their care. So some of these, the ones that were related to meaningful use, again, even though they were removed from meaningful use, none of those have changed. And some of these, the way that they were aligned with meaningful use, you still have to do them for NCQA. 5 points for this. Now, just to emphasize the must-pass part of this, you have to at least do 2 of those factors in order to get any points, right? So a must-pass means for me to get 2.5 points of this, and I have to get 2.5 points of this if I want to be recognized. So you could have done everything else, all the other standards, got all your other points and all your other elements. It won't matter if you miss this one. Same for all of them, right? Must-pass means you've got to at least get 2 factors on this one, do it, meet it in order to get recognized, period. So that's the caveat, and that's the best explanation I can give for those that either haven't really quite captured what must-pass is or are just new to it. Okay, so for 1 to 5, you basically have to give reports or list of patients needing those services. So you're going to look in the last 12 months. You can certainly use health plan data. Sometimes the health plans will send out statistics to you, right? They'll send out and say, you know, you have this many population with diabetics. Here's everyone that there are. Some of you capture things like HCC and define the risk value for certain populations, diabetics, heart patients, et cetera. You can use that health plan data. If those patients that are in that are showing on that list are comprising of 75% of your total population. So, you know, if I only have 25% of my population being diabetic, you're not going to be able to utilize that data. Hopefully that makes sense. So in addition to having reports or lists, you also need to show the materials. How did you notify those patients of those services? So we'll sort of show some of those examples for you as well. So here's a report example. Can you pull this report, right? Here's a sample report of diabetic patients that haven't been seen in a year and don't have a recent hemoglobin A1C. So I'm showing, you know, the time, it's 1 year, as you can see, and showing you who the patient population is. And I'm going to meet 3D3 with this sample report. Again, you need to remove the identification of the population. And again, you can make up whatever based on your patient population. You can say, I'm going to focus on those that are greater than 9 that haven't had an appointment, because those are people who aren't tracking well, right? They're not taking good care of themselves, and I want to improve their quality. So you can say just those that have never had a hemoglobin A1C, and you can go after, like, this patient here. Here's their last encounter, and it's past the time. Or you could say, I want everyone over 9. This is based on your patient population. Another example of 3D3, I'm looking at abnormal BMI. So these are people who don't meet the mark. We want them to have some weight control. So I first want to identify them. Here's a sample of, here's all the patients that I want. I've sort of highlighted behind the scenes I've blacked out over here all their names. And then I can have a sample letter. You know, this is the 3D3, I've got to give the report and a sample letter. Want to reach out, see you haven't come in to us for a while. We'd like to talk to you to see how we can get this in a better state. All right, let's keep moving along. Let's go to 3E. So now we have an example of a critical factor. So we'll cross this one as well so that people understand that. So basically, we're looking for you to implement evidence-based decision support. So are you using guidelines? And we'll look through, do you have guidelines to treat some of your mental health or substance abuse disorders? And to know that, you're going to have to know, well, which ones do I care about? This is, again, knowing who's in your patient population. So do you have clinical decision support around at least one mental health condition? So pick it, and you're going to pick that based on your patient population. if you're meeting some of the other quality programs, maybe you say it's depression. Maybe you do have ADD or a high percentage of bipolar disorder of anxiety or Alzheimer's, whatever that is. What is it that's going to be that I'm going to do some clinical decision support or standard of care based on the evidence guidelines for my practice? Same thing with substance abuse. Are you in a population that maybe they're having, maybe you have a high percentage of prescription drug abuse, overuse, or alcoholism? What is it that you may have maybe in a population with a high methamphetamine population? What do you have that you've got some evidence-based guideline to sort of treat those and incorporate them? Do you have a chronic medical condition? So, those are sort of easy to do. Well-tried won't count for a chronic condition, so you've got to look at something like asthma, arthritis, eczema, maybe it's diabetes. What is it that you're using as your evidence-based guideline for any chronic condition? And then for number 3, this is top things. Typically what I would expect to see is maybe for pediatric otitis media, maybe influenza, some acute condition that's constantly there that you have some type of tool and guidelines surrounding. Maybe UTI, that's a common one in adult practice, sinusitis. So depending on what type of practices you have, you want to make sure you have your right population. If you're in a family practice, maybe you are picking something that could be across both, or maybe you have to. Maybe you're pointing out your influenza, maybe you're pointing out otitis media as well. And then 4 is that you've got some type of guideline and clinical decision related to some unhealthy behavior. Alcohol, drugs, smoking, obesity, you pick it, but something that's controllable by the patient, right, not that's inherent to them. And then this is where well-child and or adult care, such as screenings and immunizations, are age appropriate. So, are you doing a well woman over 40, a well woman over 50, well men over 50, the population is 65? What are your guidelines that's gauging you to get the right screening test and or the right immunization? And then overuse and appropriative issues, I'm just going to highlight this a little bit, and that's, do you have some evidence-based guidelines? And the best thing I can correlate to other quality programs or things like, and this is, do I have people calling out for antibiotics all the time? And do I have people that I'm trying to put in place maybe so there's not overuse of testing, maybe low back pain with doing certain types of testing, or people who are seeing lots of specialists? Maybe I want to look at anyone who's got more than 2 or 3 specialists and what's going on with them, and what's the decision support and evidence base behind that. How am I providing that to my practice team as well as in taking care of my patients? 4 points. There's no critical, I take that back, there was a critical factor. Number 1 is a critical factor, but remember this is one, and I gave you an example. You have to have, in this case, to just get 75%, you have to include factor 1 because that's the critical factor. So here's an example where you can still get some points without the critical factor. And I know we saw that on the last webinar. There's some where you have to do the critical factor to get any points. In this case, you can get 50% of this. You can get 2 points without even doing factor 1. Okay, so sometimes the critical factor is required to get any points, and in this case, you can still get some without it. So what do you need for documentation? So you're going to have to provide, what did you decide, right? I gave you examples. So for 1 through 6, you're going to have to say, what are the conditions you're looking for? That's got to be somehow written down. Like I gave you some examples of diabetes or the mental health. What are your evidence base that you've picked on? So factor 1, here's the 2 we picked. We picked mental health, we picked substance abuse, this is big. That's what we're going. You're going to need the source of those guidelines and then examples of how you implemented it. So the practice is going to identify each factor You will decide what you're going to choose. It's not something that is going to be chosen for you. So it's a little refreshing for those that have been in the meaningful use world or figure out where you're told you have to meet these thresholds. You get to pick based on your patient population. So here's an example of a report. Documentation for 3E2, excuse me, of showing you that I'm capturing the documentation of the care plan. I'm giving you the reference. So in this screenshot, what's showing you here is we're going to say diabetes is what we're doing. And here's my references. Here's my clinical decision support. My evidence base is based off of Mayo Clinic and the CDC. My providers know that this is the recommendation, right? And this scenario, in this sample, this is going to meet a couple of things because you're going to see care plans is coming down the future. What the clinician's guide is are these. What's in red is this is the recommendation based on these sources, right? That doesn't mean for this patient, they're going to, yeah, I would love every patient to be under 6.5. I'd love them not to be diabetic at all. But maybe I've got a brittle diabetic that's been tracking with, maybe they're at 10. I'm just upset that they're 10. Maybe my goal is to just get them under 9 right now because they're so bad. Maybe there's barriers for them. So maybe I'm going to put in here, you know what, for this patient, I just want you to be under 9 right now. The intent of 3E2 is that I'm providing some type of support process, some decision support to my providers so they can care for their patients. Not saying that the patient's going to get to that, it's really that you've got legitimate evidence-based practice, if you will, based on recent standards to guide your practitioners and your care team on how to guide them. Same thing like things like, and I don't have that in the screenshot, but maybe we recommend an influenza for everyone over age X or with one or more chronic diseases. You know, that can be a reference that's listed here. You can embed it in the same screen. You have to be able to show that you have what your source of your documentation is. All right, well, we're getting now. We're going to switch gears to 4. And again, 3 and 4, lots of points, lots of information to capture. I would say most practices spend the most time on 3 and 4 because it's really, I don't want to say it's not executable out of the gate. It's really about you understanding your patient population. So depending on what your role in the organization is, you might say, okay, well, geez, you've got to really get people to understand, well, what's the right way? What's the right patient population? If you don't know who your patients are that you're going after and what's the best one to do, some of this is easy to knock off the list. But those first things I did, 3, 1A, and 2 were pretty easy, right? Language, race, ethnicity, getting the promise. When you get to identifying your patient population and then defining characteristics, that's where it really takes some time. You will definitely need clinical folks on your team to help. You can certainly make recommendations, but if you don't have some clinical leadership at least engaged or some input, it might be harder for you to sort of outline, say, we're going to do X, Y, and Z. So with 4, it gets down to care management and support. 20 points, again, 5 elements. So the whole thing is making sure you understand who needs care management. So first we say, here's the population we have. So who are those that need to have more care management, if you will? What type of self-care are you asking your patients to have and do or perform? What's medication management and use of electronic prescribing are probably going to be the easiest. And you'll see we'll talk about the record review workbook for element A and B here. And then I'm going to share with you examples of the shared decision support and how patients play into that. So let's start with 4A. So we need to find out who are the people of all of our population that really need more work, right, that we've got to help out more. So we're looking for people that really do have some type of behavioral issue. You know, have we had people who have had lots of psychiatric hospitalizations? Or, as I've mentioned, substance use treatment. Do I want to use some type of substance use scale, and maybe that's my screening tool to find out who falls into my behavioral health conditions. High cost, high utilization. Who's my frequent flyers to the ER? Who are the people who just constantly are being admitted? Do they need to be admitted? Or they're just going to the ER because they're lonely? I recently had somebody who, a story that was shared with me where this older gentleman was just constantly going into the ER, going to the ER. He wasn't sick, he was just ended up being lonely. So when there was different services provided, he no longer went to the ER. But finding out who are your frequent flyers, identifying those patients, and getting to those. Who's got 2 or more conditions, who's really sick, so maybe I'm a diabetic, maybe I'm controlled, maybe I'm just on oral hypoglycemic. That's probably not the person who we want to look for in element 4A. What we're looking for the people are those brittle diabetics, or maybe I'm a diabetic with hypertension, with hyperlipidemia. So who are the people who aren't controlled? Who are the people who really need some extra care for some care management? And then who are the social determinants of health? These are things like who needs extra social support, whether it's their access to education, maybe they're unemployed, maybe they're exposed, maybe they're in a high crime neighborhood. You know, do you have a way to see your population? And you can use other tools, so you can use things like Healthy People 2020. You'll see some stats where you can go and say, okay, well, my geographic region, here's how many people are unemployed, and oh, by the way, they all live around here. Who are those people? So maybe you're targeting them and you're going to do extra reach out to them. Also referrals. You know, am I referring a lot to, have you looked at who you're referring? Are you getting a lot of outside referrals? And then basically through all of this, you're going to take 1 through 5, and you're going to make sure that you are looking and that you're trying to get this entire, so you'd like to get, if I go back and accumulate, the frequent flyer who has CHF and diabetes, who lives alone, who has a cardiologist, endocrinologist, primary care, and, you know, they happen to be depressed. That's the group I'm going to put in number 6, and that's the group I'm going to target for extra care management. So hopefully you were able to follow to that. You're going to go through and identify 1, 2, 3, 4, and 5, and cumulative within that group, you're going to decide who falls into number 6. And at the end of that, you're going to say, this is the group who's going to need extra care management. 4 points. And in this, remember, we had a critical factor. And you can see this is an example. If you don't do the critical factor, you get no points. Critical factor is number 6. That's the meat of the whole element, right? I've got to find out who that. Here's all the groups I want. So unless you get number 6, you're not going to meet. Well, if you read between the lines, to get to number 6, you sort of had to do 1 through 5 in many ways. So 4 points total, and you can see how they break down. So what do you mean? A lot of it is policies and procedures. You need to understand how are you going to identify those? And I'm going to give you an example, because I know this is a heady one. It's hard to capture for many people. And at the end of the day, what you're doing is you're looking at, you need to have a report for the last one. So hopefully this will make sense in a minute, but I give the example. To me, with everyone, when I was running this, I'd have to tell you, it was really, although you can read the guidelines, it's really understanding or talking to others or getting examples of what we're looking for. Again, I'm going to show you an example now, but this is just an example. This is not something you have to do, and this is based on your patient population. But again, basics here, policies and procedures. Please remember to have practice name, effective date. Please make sure you renew and revise each year. I can't tell you that. And define what your care management. Some of you I know on this phone, and I know you're developing care management teams. Some of you already have them in place. What are your policies and procedures? If you don't have care coordinators, if you don't have navigators, if you don't have care teams, and you're looking to do this, This is some of the mind mapping that you're doing. You don't just sit down and write this policy because greater than 2 emergency visits or 3 or more active problems. Well, which active problems? Do you want to write them down? I mean, this would cover it for factor 2 or 2 or more specialists. So these are saying I have 3 or more active problems and I'm seeing 2 or more specialists. So I probably got 2 or more serious diseases if I'm getting to a specialist. And if, by the way, I'm going to the ER more than twice in a year, you know, that's going to meet for factor 2 as an example of a policy and procedure. Also, maybe I'm going to put patients ADHD, so patients who, you know, really, you know, struggle with focus on certain high-risk medications. Maybe I've got alcohol. Remember, I told you can use a substance abuse screening tool. And if I've got a certain score, maybe that's what's going to qualify me. Maybe they're not. These are the people who are going to need extra care. I want to keep them out of the healthcare system like the ER or the hospital. I want to keep their close out. I want to improve their health. Also, you know, I gave this an example. Maybe I've got diabetes and another disease, and it's bad diabetes, or maybe I'm not controlled. This is just an example. You can actually put metrics here. What the kicker is going to be is you understanding that patient population and knowing this. So, and many times it's taken a cumulative amount of reports, right? I've got to, do I have the ability to know who's in the ER when and how often? Do I have the report to know how many hospitalizations? That might be one report. Now, do I have a report that can show me 3 more active problems? You're taking all of this and sort of mushing it together to get to that 6. So let me show you what 6 looks like. Again, numerator, denominator. And I want to see that patient population and accumulate it. So remember, just to keep mentioning, dates you ran it, the years it is, what's it showing. So I'm going to show you a numerator denominator. Can I get this? Are these different reports? Do I have the ability to combine this population here with this population here and this one? And maybe there's 30 patients here, there's the same 30 here, the same 30 here, maybe there's 50. Then that's the patient population I'm going to give extra care to give a report. Essentially, this is the people that you're trying to target to give that extra care. Shoo, heady stuff, hang in there, guys. We're getting there. Okay, B. 4B, care planning and self-care, must pass. So this is really, think care plan. Care theme and care plan is really probably what you need to know for this one. And this is really that you're not telling the patient what to do. You're really negotiating with the patient, that you're setting reasonable goals. So it's one thing to say, Christine, lose 30 pounds. Christine, decrease, you need to do that because your LDL is way too high and your HDL is not where it needs to be. So you really have to look at, do you have care plans? Do you have the ability to do that? What's a barrier to me to learning? Do I have any? Do I have some, you know, problems with retaining information? Do I have a certain level of education? What is that's my challenge? Am I hard of hearing? Can I not see? You know, all of these things. Am I giving the patient this plan? You know, sometimes many of you might have gotten used to giving out clinical summaries to your patients, right? In that, does it tell me, this is your new med, take it? Does it say for me to lose weight? Does it give me a diet plan to how to do it? Does it tell me when you want to see me back? It's all of that stuff that's identifying those goals. A care plan is going to be all-inclusive, say who my care plan team members are. Again, must pass 4 points. In order to get this, you've got to do 3 of the factors to get that. So if you don't do at least 3 of the factors, you will get no points, and you will also not get recognized. Documentation. Again, I just went through that stuff. Numerator denominators 1 through 5, I don't see a lot of people who are able to actually get this without doing the record review workbook. The people who have been able to do this either have, there are some vendors that have some pre-validation of some of the stuff and they can pull that out. There are people who can do custom reports. You can go to outside vendors. You know, we've done some custom reports. We have people who use certain systems and we've developed tools for them to be able to pull stuff out of their notes and they've embedded it into their notes themselves so they can extract that data. Otherwise, you're going to be doing the record review workbook. I'll give you an example of a care plan. So in order to get the information out, or in order to do, and you saw a care plan example a minute ago as the diabetic, and all you saw was the guidelines, right? And it had the basic things you'd see. But at the bottom of that care plan, I didn't give all of it because I wasn't showing to this standard. But you could have a full care plan that says, you know, influenza, diet, here's the recommendations. Here's a very simple one that I actually had a client use. You know, it's sort of, you know, it's not bad, but it could be a lot of writing, right? I don't really want my providers and my care team to write a lot, but very simple and straightforward, right? It's covering all of those things to show you an example. So your first step is, do you have the ability, do you have care plans in your system already? Do you have some type of note documentation or some type of flow sheet, some type of application within your system where you can capture this? That's your starting point. So again, you don't have to submit an example like this. If you don't have this in your system, in order to get those patient preferences, those barriers, you're going to probably have to develop something in your EHR if you don't already have it. Once you have that, if you can get a custom report or some tool to automate it, that is amazing. However, because it's got to be in the ability to do a numerator denominator, if you cannot, then your other option is to do the record review workbook, right? So again, the record review workbook is the same thing. 30 patients. This is an extension of the other screen I showed you. You are going to go in, patient X, you're going to look into that patient's record and say, have I said what the patient's preferences are? Do I know what their lifestyle goals are? Have I identified, do I have, like in that screen a minute ago, I want your hemoglobin A1C to be 6.5 or lower. I want it between 6.5 and 7. Is that noted in the patient's chart? You'll do yes or no or report. And if some of it you can report out of your system, then you would. If you're giving clinical summaries and all of this information is in the clinical summary, and you can pull a report to show that, then you can do that as a report. So again, record review workbook usually means a lot of someone's time to go into the chart reviews. 30 patients, but in order to submit, you're going to have to do that. If you're audited, you'll have to go back. All right, the next two are a little bit easy, or at least this one is, for sure, medication management. Many of you have been doing this for meaningful years. So again, you're looking at, do you review and reconcile your medications? Am I doing it when people are coming to me from outside of the care? So, you know, if I go to the hospital, am I looking to see once they've been admitted, or maybe they went to go see a specialist, am I checking to see which medications are new? Am I updating their record for it? Pretty straightforward on this. Do I have the ability to see when they were last assessed? Does your system have the ability to document over-the-counter medication? Can you free text it in, or does your system already denote whether it's an oral medication or over-the-counter? So you don't have to do all of them to get points. So in the case of your system doesn't have over-the-counter or doesn't have the ability to document oral medications or free text, you could still get 100%, but there's 6 factors, a total of 4 points. And again, pretty straightforward. For some of these, you absolutely will be able to give a report to. So you're going to need to do a report or a record review workbook. For medication reconciliation, many of you are doing meaningful use, right? That might be something that's still available to you in your report, and you can easily pull that out. So if you can do that, you'd pull that report and you'd include it. But my guess is the majority of you for both 4B and 4C will have to use the record review for a portion of it, if not all of it. So again, you'll either say yes, no, or report. In this case, if this is something, you know, transition of care and I'm going to reconcile my medications, because that was a menu item at one point for many people, and there's been some modifications. But if you still have access, you're still doing this, certainly go and pull them. This one's probably going to be the easiest one, and you're going to put report for every patient. Okay, electronic prescribing. So this is, you know, are you sending them electronically? So not by fax, not by printing them out, not by calling in the RX, but if more than 50% of your items are actually being called electronically submitted to the pharmacy. Do you have drug formularies in place? Does your system have the ability to do drug-to-drug or drug-to-allergy? And do you get any type of alert in your system? If I'm on Coumadin, but, you know, I can certainly go to Warfarin, the generic, is there some type of alert that says, hey, look, this is going to cost the patient more? Remember, this is about improving care, keeping costs down. What's driving you to pick a generic a brand name is that the only thing that's available to the patient, the only thing the patient's responding to. So this is pretty straightforward, these 4 factors, as well as the points. So you do all 4, you get 100%. I'd like to say that that's probably the easiest one to actually capture, as well as the medication management. It's relatively easy for most people. So you need 2 things. For 1 and 2, you're going to need a numerator and denominator get. And for me, because of meaningful use, you probably can still get both of those rather easily. In addition, you're going to have to show screenshots for the formulary decision, the drug-to-drug, and the system alert. So I'll give you some examples. I think most of this is intuitive, so I'll try to get through this because I do want to make sure we have some time for Q&A in case people have questions. Or maybe you all want to chat amongst yourselves and see how you're doing. So straightforward, right? Electronic prescribing, meaningful use, CPO entry, am I entering into the system? Same thing, am I giving during electronic entering into the system? These are very simple. It's practice level, keep that in mind. Make sure you put the reporting period, it's gotta be 3 months, and that you're saying, you know, which one it's going to. For the other ones, for 4D, I'm gonna give you some examples so you can see. So do you have the ability to show drug-to-drug interactions? Does your system alert to you when you're giving something that you shouldn't be giving? Here's another example. In this example, you know, maybe I'm prescribing Actonel, and you can see that in this vendor system, it's yellow, but the green's denoting that, hey, it's a little bit cheaper and there's a generic. So do you want to give the same thing but give it in generic? Does your system have any type of alert or identification? This is the type of screenshot that people are looking for when you're submitting for NCQA. All right, we're almost through 4E, the last one, and then we'll talk about the 2011 to 2014 and some tips and tricks. So self-support, so it's really engaging the patient. Remember I talked about the overall writing characteristics of patient engagement and shared decision-making. So the first one, many of you, for those of you who are meaningful use experts and this has been your world and now you're asking to come into this world, that makes sense, right? Patient education, are you giving that? What's the number that you're giving it? And do you have that number available to you in a report? Do you provide education materials? Do you have some type of self-tool management? So am I asking people to maybe do diabetes? Maybe I'm asking them to take their blood sugar 3 times a day. Do you give them some type of pamphlet where they're tracking and they're sending it to you? Or maybe they're using some type of tool. Maybe you're asking them to submit in some device on their phone. Maybe you've built a tool, maybe they're using Fitbit data, and maybe they're BMI, right? And I'm going to submit that data to you. I'll talk a little bit about shared decision-making aids because I think a lot of people don't get what that means and how you are giving the patient, and this is, I want to say I grew up in old school and the doctor told me to take this and I just said yes. But you know what, ever since all those commercials come on TV and people see the ads, oh, I've heard about this one. It's really laying out, here's all the drugs in that class, here's the pros and cons, here's the price, here's the benefits, and engaging the patient and the physician say, yep, all of these would work or these won't work for you because of X, Y, Z. Here's what's left, and really giving the patient the ability to make their own decisions. Do I give some type of health education class, whether it's, and looking, whether it's peer-to-peer, I get 2 patients, maybe I've got a brand new diabetic and I've got a diabetic there and I'm connecting them, or maybe I'm just giving diabetic education classes or weight classes, obesity classes, asthma control classes. And then do you have in your system, in your organization, not in your system, do I have community services? Maybe I have a teen pregnancy, maybe I have healthy pregnancy group, maybe I have an asthma group because I have maybe a high asthma population. So do I have either some type of support group out there, some type of service, education? You have to find 5 community resources. And typically what I see is, this would be on a pamphlet, or maybe it's on your bulletin board in your front office. Here's our support groups, a bereavement group. So one is to say that you have something available to your patients. It doesn't matter what the group is. So it's based on your patient population, right? What's your resource list? Smoking cessation classes, weight management, parenting, what is it that you want that you post that these are services that are available to you outside? It can be on a bulletin board, it could be on a flyer. And then secondarily to that, number 7 is, do you query your patients and ask them, hey, how was that? So one thing is to provide a resource, and you're saying, here's a resource, but it's really connecting. And remember, a patient-centered medical home, it's a neighborhood, it's a community, right, that you are saying, here's where to go. Do you refer to them or offer them that this is a service? And part of 7 is that you are engaging your patients to query them, how was it, and you're rating what that service was. Because obviously the intent that you're reviewing and you're getting the feedback from your patients, and that you're adjusting that, right? Maybe you're going to do referrals differently. Maybe you would remove somebody. Maybe they'd say, oh, I went to this place, I didn't go there, and it was wonderful. Maybe you'd add someone to your list. So it's about keeping your patient population as healthy and engaging all of the community. 5 points for this: no critical factor, no must-have. And then for number 1, we need a report. I'll show you examples of that in a minute. And then for 2 through 5, you need examples of each. So again, I gave you verbally. I don't have screenshots for all of these because I just didn't want to share other people's phone numbers and post stuff like I'm recommending. But, if you have a teen pregnancy or a parenting group, or maybe hospice referrals, or how to deal with weight loss, what's the name, what's the phone number. If you have a pamphlet, you could take a picture of your bulletin board if you post those services are in their room, but you need an example of each one of those. And then for 6 or 7, you have to show that you at least have 5 and that you've got the survey results. So I'll show you some education on 2, and we'll do an MU report. So here's the MU report, right? Straightforward. Do I meet 10% practice level? Make sure it's 3 months worth of data, that you're putting that in your submission on your report that you give. And then educational resources. So do I provide some type of resources to the patient? Here's how to meet that. Do I explain what diabetes is? What are the tools that I'm actually giving to the patient? And I talked about, so that would meet 4.2E. Let's talk about that shared decision support. So I will tell you that this is probably the best website I've seen that can help you with that. So if you don't currently have this one and you're thinking about how to implement it, I will tell you this is probably the best one. And I'm going to give you some examples. Here's one for weight gain, this is for depression, right? Yeah. So, there's tons of stuff at this Mayo Clinic for shared decision. And these are what I think are very easy to read or to understand for the majority of patients. And some might take some coaching, but I just love the grasp of it. So if you're starting this and you're struggling with how to meet this one, take this to whoever your clinical leadership or provider. My guess is most of them, being a clinician myself, most of them would want to weigh in. They're not going to just want people to give this out. And there's tons of different disease states. I just picked depression, but here's an example, right? Some of these drugs you see on the news and stuff, and just because I failed one SSRI doesn't mean you wouldn't prescribe me another one, right? But if I'm debating which one, you say, well, you could do this one or that one. Some people care about this, right? I'll tell you, as a woman, I would care. Anything where I see weight gain, I start to cringe. So this is about giving the patient to say, well, which one? Okay, well, just so you know, for this class of medications, there's weight gain, and there's also sexual issues. So which one do you want? And this is letting the patient, based on their life, their lifestyle, with some guidance, right? It's not about the patient taking which med they want, right? There's some provider discretion here to say, well, that's not appropriate because you failed this, or I believe these would be your 3 best to do. Here's some documents. Why don't you take a week, come back and tell me what we'd like to switch you to. That's the intent of 4E, that the patients, we know from data that if patients engage and really make informed, makes them accountable and their health comes are improved. So that's the intent. All right. So I know it's Friday, I have 9 minutes, and we'll go through the crosswalk. Pretty straightforward because I think most of you are in the midst of becoming PCMH, but I know I have a few of you that are on 2011 seeking 2014. So what I've done here, and again, you will all get the deck at the end. I'll send out those emails. I'll probably do it first thing Monday. But I highlighted the ones you need to focus on. You will see that between 2011 and 2014, compared to Standard 1 and Standard 2, there's quite a lot of changes. So all I did was highlight the new things. If you're already doing 2011, there's things you might not have to do anymore, but I really wanted you to focus on the areas that are new and changed. And because they've changed in these 2 a lot, I've called out each one. So, you know, if you're capturing the legal guardian healthcare part, just cross off, that's easy. Focus on the ones that you know you haven't been captured. The meanings we use probably, you know, in 2011, they weren't, you know, for the electronic record and the patient family history. As you remember, in 2011, that was, back and then, it was stage 1 meeting for you, so we don't even talk about that anymore. So that's new, probably not, that's probably low-hanging fruit. You know, I don't want to say you don't care about, people probably doing. Focus on the ones on the bottom would be my recommendation that are brand new to you or that you really got to look at your patient population. You can download that crosswalk. Here's that crosswalk is at the top of this link that sort of aligns very easily. I've just succinctly pulled out for you the new ones that you need to look at. And again, the ones that I look at are the ones at the top, certainly the 4A, 1 through 5. That measure has sort of changed on you quite a bit. So really dig down on that. Again, know your patient population, treat the right patients, the high risk, the ones that really need the help, with the caveat that you're trying to do the best you can for your entire patient population. That's what the overriding goal is. All right, so just like the last time, those that were here before have seen this before, gap analysis, that's your first stop. Focus on the must-pass. If you're brand new and you're looking at 3 and 4, 3 and 4 can for most of you, you can say, oh, I can't, I'm happy this is Friday, it's the weekend, because you just sort of said I'm overwhelmed. Take small steps, focus on the must-pass first on those 2. Look at those in detail. Knock those off before you try to get into those heady ones with the record review workbook. Things like policies and procedures, in my eyes, although they take time to write, sometimes they're easier. Now, the ones where you have to write the policy and procedure about your patient, which ones you're picking, you've got to take the time to pull all your reports, evaluate the data before you're going to get to there. And then the ones that are simple to get, like, you know, the ones that are MU or the samples, knock those off, right? If you're building out your stuff right now and you're trying to put it into the survey tool, put those out. So, you know, as soon as I cross a line through something, I feel like I'm making some progress. That will make you feel like you've got some momentum, because I know this transformation can take time. And then, as I mentioned before, if you don't have a tool, there's many tools out there. We use a tool when we do gap analysis first time to quickly look, so we know what to focus on. So in this scenario, I'm going to focus on this one. This is the one I'm not working on. So let me focus on this one. If I've got all this other stuff, then I know I've got it. If I don't care about getting 100% and I've got bigger fish to fry, then I'm going to move on, because I'm not that bad off at 75%, and I'm going to go to another one. And again, we've developed and taken some of the tools that are out there and even expanded upon them to really break down what's got to be in the policy and procedure. And part of that is because we're PCMH experts, so we'll quickly read a policy and procedure and say, nope, you need this, or nope, you need that. These are little things you can quickly do so you can move along and get to the ones that are going to take you longer to do. References, again, go to NCQH, get your download the standards, get at least the appendix so you know the latest and greatest, and the crosswalk if you're in the middle, going from 2011 to 2014. And as usual, I'd like to thank you. I know this is a lot of information. So me and my puppy are going to say, well, she's not a puppy, she's 8.5 now, are going to say thank you. And again, at the end of the session, when you close out, if you were not on 1 and 2 and you want access to that information, I will send it to you. You're going to have to tell it to me in one of two ways. Either I'll send you this email and you can ask for it when I send you this recording and this slide deck, because I will send it out, or you can also put it in the at the end of the session. So with that said, I'm going to ask Sin to open up the session. I do see that there's some Q&A. I'm also going to open up a poll. So the first question on the poll, I would like those that are still on the line as we open this up and I look at the Q&A. I am considering doing another session that's not posted yet, and that is for those of you, I'm looking to see when you're planning to implement or actually submit your survey tool for NCQA or you get formally recognized for PCMH. If you're mid-flight, just tell me that. What I'm considering doing is showing you, you hear things like survey tool, you'll see things on NCQA of ISS tool. If you want some tips and tricks or just some basic navigation on a webinar with Q&A at the end, I'm happy to put that together. I'm thinking about it, but you know, I've got quite a few of you that keep coming back to these sessions. So these sessions, you can drive what comes next. Standards 5 and 6 are coming next. For certain people that are on certain vendor in August, we're going to give you some tools that we can use. And then later in the year, for those of you who have specialists, we're going to talk about PCSP. And you can see them from our webcast and from our website and register for those. But if there's something more, because this series will end with 5 and 6 coming up shortly here. There's more things about PCMH, because some of you have asked that. Tell me more specifically what you want, because you could drive this bus as much as you like. Okay, so for some time remaining, I'm going to see what questions there are. And most of these questions about all those slides were viewed. So yes, you'll get the slides, you'll get the recording, I will send them out. And Sin, if the lines aren't open, feel free, and if you don't have questions and answers, but there's folks on the phone that want to talk to other people, don't hesitate to chime up. And I'll stay on the line for just a second. I hear noise. Any questions? Viewers? Have I pushed everyone over to the other side with this presentation? Just say yes or no. All right, quite the quiet bunch. And I'm not that mean to call on some of you, even though I know I've been talking as loud as you on the phone. All right, so for those of you who haven't done the poll, I do appreciate you join the polling questions. Again, you can help with devising any future sessions outside of the next one. Our next session will be on a deep dive, similar format. I did query most of the people who've been attending if they like this format. So I'll send the same type of format for 5 and 6. And I hope to see most of you there, and I'll send all of you out the deck and the formal recording probably Monday or Tuesday of next week, and don't hesitate to reply to me if you have some questions. I know they're pretty simple. I'm happy to answer them and help you along with this journey. I thank everybody for their time today and have a great weekend.